Today we have a slightly different format of CME. Today is an international speaker program. It's a session on vertigo, for which we are honored to have Professor Owen Judd, who has come all the way from UK to enlighten us on this topic. Thank you, sir. For the Indian context, it's my pleasure to have with us Professor of ENT, Dr. INDUDHARAN, who will take us through the diagnostic and treatment hurdles that we face daily in the management of vertigo. To get the dice rolling, I invite over to the podium our scientific chairman, Professor JILSE, to moderate the session. Over to you, sir.
Very common topic, that is vertigo. I invite Professor Owen Judd and Professor INDUDHARAN and Dr. PROF Singhal to the dais. Every day in our clinical practice or in our OPD, we are getting lot of cases of vertigo. Some people will come saying that I am having reeling sensation. Somebody is coming and telling us I am having giddiness. Somebody coming and telling us fainting. Somebody have got reeling. Somebody is telling I cannot hold my head on the neck. Somebody with a profuse vomiting and giddiness. Some people will come with a distressing symptom where they cannot even stand even for a minute. And like that, the patient is coming with very distressing symptoms of vertigo. They present like tala karakam, tala tiriyunnu, അടുത്ത് നിൽക്കുന്ന ആൾ കറങ്ങുന്ന മാതിരി തോന്നുന്നു. Some like that the symptoms are coming. And when we investigate the case, most of the cases we come into a very grave diagnosis or very serious complications in medicine. So vertigo is a very important symptom which we cannot neglect. And I like to invite Dr. PROF Singhal to introduce the subject. Please.
Thank you, sir. A very good evening to all of you. I am Dr. PROF Simran Kaur and I work as medical advisor in Abbott. First of all, I would like to thank you to give us this opportunity to have this sponsored session. And coming to the topic, so as sir explained very well, that vertigo is one of the commonest complaint that you all must be coming in your daily practice. And right diagnosis is very crucial to reach that right treatment. But the problem is misdiagnosis is a challenge and we need to identify it and address it. So let's hear it from our speakers that what are the potential reasons or challenges and how to address them. So first of all, I would like to invite Dr. INDUDHARAN to kindly share his perspective.
Professor INDUDHARAN, as all of us know, he is a graduate. He was started his career as an assistant professor in THRISSUR Medical College. Then he went to Malaysia, where he was working in the University of Sarawak in Malaysia. Then he returned and he joined as professor and HOD in AMRITHA Institute of Medical Sciences, and he was there for a long period of 8 years. In between, I also got an opportunity to associate with him because he was HOD of ENT department when I was working there as HOD of medicine. He is a very good clinician, very good administrator, and a very good orator, and a man with a common clinical sense. I invite Professor INDUDHARAN to deliver his speech.
I'm very happy to see the medical fraternity of Cochin. I had lived in Cochin for almost 10 years, AMRITHA Institute of Medical Sciences, and then subsequently Cooperative Medical College, which is Ernakulam Medical College now. I was a bit embarrassed when I was called to address you because I saw the international name, Owen Judd, and I was wondering, what is that I am going to teach you? Both of us belong to the same ENT fraternity, and you people are at a higher level, the central issues of vertigo. I had a program in my mind with a PowerPoint presentation and slides and all. But then I was wondering, well, the international faculty is our chief guest. We should be listening to him rather than me talking about the topic of vertigo. But people had sent the schedule in which 25 minutes was allotted to me and 30 minutes was allotted to Professor Owen Judd. So probably I will just highlight to you what is this peripheral vertigo about. And according to this schedule, Dr. Owen Judd is supposed to tell us about the misdiagnosis and the mismanagement of vertigo. So I'd rather talk to you about management of vertigo or diagnosis of vertigo. Instead of misdiagnosis, I will talk to you about the diagnosis of vertigo. To understand the problem, you should know a little bit about the anatomy of the vestibular system. It's one of the most complicated anatomy in the field of medicine. But I'll be describing it to you in such simple words that most probably you will be able to digest it. You would have learned it during your old medicine days, but once we part ways in different specialities, we tend to forget. That is natural. So instead of putting up slides and all, I'll be drawing pictures in the air and I'll try to describe about the peripheral vestibular system. We have a right ear and a left ear and two peripheral vestibular systems on either side. One is a mirror image of the other. We talk about 3D, 4D, 6D and all. Our vestibular system is a 10D structure. It is in 10 dimensions. That itself tells us how this nature has modified our system. And if I take the right side, I have a superior semicircular canal, I have a lateral semicircular canal, and I have an inferior semicircular canal. These three semicircular canals each have a dilated portion called as the ampulla, inside which is the neural system for maintenance of equilibrium is lodged. Because they are semicircular canals, they cater to the angular motions of the human body. Whichever angle you turn, the semicircular canals detect. And these three semicircular canals open into a vestibule. That receptacle or the vestibule has two balancing organs. One is utricle and the other one is saccule. Utricle caters to the horizontal motion of human body, just like you are going forward in a car or reversing in a car. Saccule caters to the vertical movement of the human body. Both are linear motions. One is horizontal and the other one is vertical, like you go up in a lift or come down in a lift. So much so that we have three ampullae on one side, one utricle and one saccule. That means 5 balancing organs on one side and 5 balancing organs on the other side. In the ampullae, the neural cells have ciliae which are covered by a gelatinous material, so that during angular motions, these ciliae have restricted movements, or rather they have an inertia within the jelly-like substance called as a cupola. So because of that inertia, some of the channels of these cells open up and the cell undergoes depolarization and electrical signals are sent to the brain from all the 5 systems. So only 3 systems have this ampulla. Utricle and saccule being in a large receptacle, nature could not provide a gelatinous substance to touch the roof, so as to provide inertia to the hair cells of the utricle and the saccule. Therefore, these hair cells rest on a gelatinous substance upon which sodium carbonate crystals are perched, what we call as otoconia. This autoconia gives weight to the cupolar system or the jelly substance system, so that in utricle and saccule, the hair cell inertia is provided by the gelatinous substance and the crystals perched upon them. So that gives you a rough idea. And then beyond the receptacle, we have a coil structure called as the cochlea. All the three are connected, the semicircular canal, the receptacle vestibule and the cochlea are all connected. And inside the bony structure of these three structures, we have a membranous structure also. The content of the inside of the membrane chemically is totally different from the content of the outside of the membrane. Meaning endolymph is high in potassium content and perilymph is high in sodium content. They have a electrically different activity. So much so about the anatomy. And from these structures, we have vestibular nerves and the cochlear nerve taking the signals to the brain, and it reaches you, the central system. From us, it reaches you. We have three nerves specially carrying the signals to maintain our equilibrium. Those are the superior vestibular nerve, the inferior vestibular nerve, and a third nerve called as the cingular nerve, which specially caters to the inferior semicircular canal alone. Phylogenetically, this inferior semicircular canal is very important. It developed during the development of the animal kingdom. This inferior semicircular canal came into existence much later. And therefore, it has got a special nerve, the cingular nerve, which takes impulses to the brain. Because this inferior canal is the most dependent of the vestibular system, debris from the receptacle, from the utricle and saccular systems, the degenerated crystals and all, the autoconia, sometimes gets dislodged and comes and lodges in the most dependent part. When we stand erect, the most dependent canal is the inferior semicircular canal. I will tell you something. It is because of this inferior semicircular canal that we human beings stand on two legs. Not even a doll can be made to stand on two legs unless the leg is created like this. We stand like this because of the inferior semicircular canal. Only few animals stand on two legs, like a chimpanzee, like a gorilla, like probably an orangutan, etc., etc. All other animals stand on four. They may stand on the hind legs for a short while, but they cannot ambulate themselves on two legs. And we owe this development to our inferior semicircular canal. And if you go backwards, you would have seen photographs of Neanderthal man walking like this. And how did we become straight like this? Our lateral semicircular canal, even though it is called as lateral, it is not exactly horizontal. It is tilted about 30 degrees from the surface of the earth. So, surface of the earth is a curve like this. Earth is not a flat place as people used to believe in olden times. Earth is a globe. And we stand on this arch. To maintain our balance, we needed to stoop forwards about 30 degrees like this. And gradually, the nature tilted the lateral semicircular canal 30 degrees upwards so that we owe the straight posture to that. Probably many of you may not be knowing all these things because I am especially interested in vertigo, and I had been giving talks on vertigo for the past probably 15 to 20 years. So I pondered into all these things. Anyway, now having taught you, having told to you about the equilibrium apparatus in human body, I will tell you what is my concern. My concern primarily is only 5 diseases. The most common disease which causes vertigo is, as you all know, benign paroxysmal positional vertigo. I would rather put number 2 as vestibular neuronitis. Number 3 as Meniere's disease. Number 4 as labyrinthitis. Number 5 as vestibular migraine. And number 6 doesn't belong to my specialty, which is psychogenic vertigo. So, if you know how to differentiate, how to diagnose, and how to treat these 5 diseases, 90% of vertigo is over. Then comes the stroke, the cerebellar ischemia, your posterior inferior cerebral artery syndrome, and we have a special syndrome called as anterior inferior cerebral artery syndrome, in which we are very much interested. So, idokku rest of the central systems. So, how do you diagnose these 5 systems? It's 5 diseases or 6 diseases. It's rather easy actually. Number 1, you don't need any special equipments or instruments. BPPV is diagnosed by the history of the patient telling you that I get a disequilibrium or vertigo when I turn towards the right or to the left side in my bed, or when I get up or lie down. It is episodic, it is short-lived. The vertigo remains only for approximately 20 to 30 seconds, and then it's over. But it is such a fearful feeling that the whole world is spinning around you and you feeling nauseated, sometimes autonomic misbehavior, you pass urine or sometimes pass motion because of the autonomic symptoms. That is benign paroxysmal positional vertigo. You can diagnose it from history. Number 2, I said vestibular neuronitis. That is a post-viral inflammatory situation of the vestibular nucleus or the Scarpa's ganglion. Because only the vestibular nucleus is involved, there is only a vertigo, but instead of it being episodic, it is a rather continuous event lasting for about 10 to 15 days. Because it is a viral disease. You may get a prodrome of an upper viral catarrh, nasal catarrh, or throat pain, viral pharyngitis, or something like that, followed by rather continuous instability which subsides by itself. During an acute attack of BPPV, you treat with Stemetil. During a persistent imbalance of vestibular neuronitis, again you treat it with Stemetil. Number 3, what did I say? Meniere's disease. Unlike these 2 diseases, Meniere's disease also produces episodic vertigo, but unlike these 2 diseases, it is associated with hearing loss. In Meniere's disease, otherwise called as endolymphatic hydrops, there is more production of endolymph, so much so the membranous labyrinth gets distended and distended. It happens not only in the vestibular system but also in the auditory system, and therefore as the endolymphatic system expands, there is a feeling of imbalance, there is a feeling of hearing loss, and at one point, like a balloon, it ruptures, resulting in a violent vertigo, vomiting. But with the rupture, the pressure is released, and therefore the hearing improves slightly. And then you come to the hospital. We all give injection Stemetil. That is only injectable anti-labyrinthine medicine known to most of us. But definitely it is not the first in controlling vertigo. The best and the first labyrinthine sedative is diazepam. But most often we don't use it straight away like that. Most of us use prochlorperazine injections. So, in acute attack, total rest, calm, comfortable room, and injectable labyrinthine sedatives. After the first attack, a second attack, a third attack, a fourth attack. As the attacks progresses, the hearing becomes lesser and lesser and lesser because of the pressure, more and more auditory cells are damaged. What is the treatment? There is only one answer. There may be so many answers, but the first and foremost is diuretics, Diamox, acetazolamide, to reduce the excessively produced endolymph. That is the treatment. So, third over. Now, fourth. What all did I talk about? BPPV, Meniere's disease, vestibular neuronitis. That's all, no? Now comes labyrinthitis. Labyrinthitis is either a viral or a bacterial infection of the whole labyrinth, meaning all the three semicircular canals, the vestibule, the utricle and the saccule containing space called as the vestibule, as well as the cochlea. Because it is a continuous inflammation of the whole system, it is a catastrophic event. The patient will have severe vertigo, vomiting. If it is a bacterial one, there will be rise of temperature. It's a undescribable event. The patient is totally bedridden. If he opens his mouth, the whole thing spins, he vomits, severe disease. You treat it as an emergency. You treat it with antibiotics, you treat it with antivirals, you treat it with symptomatic measures, lot of stomatil, and then you control it. And then once the disease subsides, your balancing organ is damaged, your autologic system is damaged. And the damage is more or less permanent. So diagnosing it early is most important. So I have finished the fourth one. Now the fifth one is vestibular migraine. You all know migraine, we all know migraine. It is a spreading cortical electrical activity, a spreading action potential, spreading over the cortex of the brain, giving you acute headache. Again, it is episodic. Sometimes the cerebellar peduncles and the cerebellum also gets involved in this spreading electrical activity, resulting in simultaneous vertigo. And you treat it like any migraine, anti-migraines drugs. And if it is associated with imbalance, again, you add stomatil. You will be wondering why I am telling the name of only one drug. Because I want to teach you as minimum as possible. Not because Abbott is sponsoring it. Whoever is sponsoring it, this will be the method. So, easy diagnosis, easy management. And the sixth one is psychogenic vertigo. Unlike all this episodic and continuous vertigo which I described in the 5 situations, in psychogenic vertigo, it is continuous, lasting for weeks to months to years sometimes. And there will be no positive clinical findings. Every time the lady will be telling that whenever I walk, I have imbalance. Probably she has peripheral neuritis because of a long-standing diabetes. So that is a misnomer. It's not actually vertigo. So I have talked to you for more than 20 minutes, I believe. My time is over. I have highlighted the principles of the peripheral vestibular system and the main 6 diseases which we come across. Incidentally, let me tell you, why are we so very much interested in ICA syndrome? You are interested in PICA syndrome. We are interested in ICA syndrome. ICA syndrome is something, see, in PICA syndrome, it is a stroke. In ICA syndrome also, it is a stroke. But here, the stroke involves only the ear. It is a stroke of the ear because the vestibulocochlear artery is a branch of the anterior inferior cerebellar artery, and any thrombosis, any spasm of it immediately takes off your hearing. It produces sudden sensory neural hearing loss. And how do you treat it? You treat it like a stroke. You give high doses of methylprednisolone, either transtympanic or systemic, and then if you're lucky, if the treatment is early, it gets cured in almost 80% of people. So when I say this, treatment of vertigo appears to be very simple. It is very simple provided you diagnose it properly. Now, I finish with this briefing. Let me hand over this to Dr. Owen.
Thank you, Indudharan sir, for your excellent presentation. I think all of you had a feeling of attending a previous END clinic during or END lecture class during our MBBS days. I am very sure that we are having lot of questions and we are having lot of experiences to share with the Professor Indudharan sir, but we will consider it at the end of the second presentation. Then we are moving to the next presentation by Professor Owen JUDD. He is a consultant ENT surgeon and Department of Otolaryngology, Royal Derby Hospital, and he is the clinical dean and associate professor, University of Nottingham School of Medicine. He is a visiting professor of Balance Medicine and the medical director of Park Hospital and Clinic. And it is learned that he is one of the and only handful surgeons in the world to hold the dual fellowship of Royal College as both physician and surgeon. With these few words, on behalf of all the physicians assembled here, I invite Professor JUDD for your presentation. Please, sir.
Namaste, Bharat. This is my third time to Cochin. It's my first ever visit to India was to Cochin about 10 years ago with my colleague and predecessor at work, Dr. Sharat Mohan, who is from Cochin, and he's a Keralan. So I'm going to talk to you about how to stop the world spinning. So it's really sort of the nuances of diagnosis for patients with acute vertigo. But why is dizziness such a difficult problem? And I'm sure you're all exactly like me in that when a patient comes into your clinic, a general clinic, you have a 10-minute appointment and they tell you that they're horrendously dizzy. It's a complete heart sink because you cannot really fix a dizzy patient in 10 minutes. You need to take a really good, careful, detailed history. These patients need a significant length of time. And it's because it's a very complex disorder. So dizziness in itself could be a symptom of neurological disorder. It could be a cardiovascular problem. It could be psychological. It could be endocrinological. And what tends to happen is we can compensate for a problem with one system with another. But if we start to lose issues with our balance, we find it more and more difficult to compensate. Our balance system generally is a combination of vision, proprioception, and the vestibular system. If we lose one of those inputs, we can compensate with the other two. If we lose two, we decompensate, and that's where we become very, very unstable and fall. The other difficulty we have with these patients is the patients themselves find it extremely difficult to articulate their symptoms, to describe to you exactly what it is they're feeling, and they need time to be able to do that, which often is precious. And the other difficulty with dizziness is identifying whether a patient is having an acute central effect or a peripheral disorder, because they often present equally in acute vertigo. So the most important part of diagnosis for any patients with dizzy symptoms is a history. And for vestibular disorders, you can actually get 90% of the diagnosis purely from the history, and that is the most important part. So taking your time with the history is crucial, and getting answers to these 6 golden questions is the most important. The first question, is the patient describing vertigo? So my colleague mentioned and talked about what vertigo is earlier on. So it's that hallucination of movement, that sensation that the patient is moving when they know they're not moving. Classically, it's a spinning sensation, but it can be a feeling like you're rocking, swaying, bobbing up and down. That describes vertigo, but sometimes the patients say they're dizzy when what they really mean is they have disequilibrium. They feel unstable, they can't walk in a straight line. Or it may be that they're having presyncope. They get very profoundly lightheaded as if they're going to pass out unless they sit down. Or it's a vague lightheadedness or a true ataxia. So the first part of the history should be to identify exactly what it is the patient's describing. The second question is to describe their first ever episode of dizziness, however many years ago, because that can help you with a clue as to what might be going on and what preceding and concluding problems this patient is currently having. You want to describe when, how the symptom occurred, and have the symptoms changed since that time, or are these episodes the same as the episodes they were having previously? The third question is how long an episode is going on for, and this is really crucial. So if a patient's describing vertigo and it's lasting just for seconds, the most likely diagnosis is BPPV, but it could also be conditions such as vestibular migraine or even a TIA. The symptoms might be lasting for minutes to hours. If they're associated with other features, we could be looking at Meniere's disease, vestibular migraine. If the symptoms are going on for days, as was already previously been described, this is very typical for vestibular neuronitis, a post-viral inflammatory disorder. But if the dizziness is persistent and the patient says it's there all the time, it never goes away, it's constant, then that makes you think that there's an underlying psychological component. The fourth question is are the symptoms positional or postural? So does the patient describe it in bed when they turn over in bed, or is it more a postural issue when they sit up in bed or stand up from a chair? That can differentiate between a BPPV type problem or a postural hypotension. And changes in posture can often help elucidate the diagnosis. And probably one of the most important questions is, are there any associated features? And by associated features, we want to know, are there any neurological features? Are there any cardiological features? Are there any psychogenic features or auditory features in their symptoms? For example, if the patient says they become profoundly lightheaded, they get sweaty, they hyperventilate, they may have palpitations. Could it be cardiovascular? Could this be a panic attack? If the patient describes photophobia and phonophobia, changes in their hearing, changes in tinnitus or headache, we could be looking at a migraine phenomenon or a Meniere's disease. And speech disturbance, of course, is a worrying sign of a central disorder. And then the final question is there anything the patient does that either exacerbates or relieves their symptoms? Do they use medication? What medication are they currently taking? Is that potentially are their symptoms potentially a side effect? Are the symptoms made worse by light? Are they stimulated by light? Are they made worse in darker environments? And we'll talk about that a bit later on. Does sound provoke the vertigo? Does their position, their posture, or movement provoke their vertigo? But the really crucial question when someone presents to you with an acute onset of vertigo is it a central disorder or a peripheral disorder? So what we really want to know from the history is, are there any markers that might indicate this being a peripheral disorder or a central disorder? And so there are some typical features in the history that might help you decide as to which one this is likely to be. Peripheral vestibular disorders tend to be provoked by position or movement changes, and someone who's having a peripherally driven vertigo will keep their head still, because every time they move their head, their symptoms get worse. They may also have visual changes, they also may have auditory changes. But crucially, they can stand up. You can stand, they may feel unstable, but they can usually stand and take a few steps. And peripheral disorders tend to generally be paroxysmal. So asking the patient that history of have they had any dizzy symptoms before, however many years ago, and to describe those might indicate that this is just a common recurrent paroxysmal disorder. Whereas central disorders tend to be slowly, gradually progressive over a period of time, or they can be a sudden onset without warning exacerbation of vertigo. Patients are often prostrated, and the most important feature is that they cannot stand unaided, unlike those with a peripheral disorder. So if we're starting to think that the patient in front of us with acute vertigo may have a central disorder, such as a stroke, then we need some hints to our diagnosis, and that's where that word comes in. So I'm sure many of you in this room will know what hints is. These are 3 simple bedside tests, the results of which are more sensitive to diagnosing a stroke than an early diffusion-weighted MRI. And it involves a head impulse test, looking at the patient's nystagmus, and a test of skew. So we're going to run through those to show you how to do them. So first of all, what the head impulse test is it's testing the vestibular ocular reflex. So my colleague described the anatomy and physiology of the balance system very eloquently and said that the signals are then sent to the vestibular nerve in the brainstem, and at that stage it's over to you. But in actual fact, that is where the main part of our balance sits, in the vestibular ocular reflex. So we're able to read these words on the screen despite the fact that our heads are constantly moving. Every time we take a breath in, our head moves up and down. Every time we have a carotid pulsation, our head nods minutely, but enough that if your eyes were fixed in your head, the whole world would be constantly moving. So what the vestibulocular reflex does is it takes that signal from the vestibular nucleus on one side and it transfers it across the brainstem to both sides of the brainstem, to different cranial nuclei on either side, to allow the eyes to move conjugately in the opposite direction to head movement. So if I turn my head to the right whilst looking at the back of the room, both my eyes move to the left. And they move conjugately in order to keep that, what I'm staring at and what I'm fixing on, crisp on my retina. And it's the vestibular ocular reflex that does that. And what it does is it sends signals from my right vestibular nucleus across to my left abducens nucleus and my right oculomotor nucleus, which allows my eyes to move conjugately in the opposite direction, hence keeping everything in focus. If we lose our inner ear, we don't stimulate the vestibular nucleus, and we lose our ability to be able to use our vestibular ocular reflex. And the way we test that is we can get the patient to stare at our nose, hold their head and turn their head about 30 degrees to one side, with asking the patient to fix on the nose, and then rapidly and unexpectedly turn the patient's head back to the center. And the eyes should stay fixed on your nose if they have an intact vestibular ocular reflex. If their reflex is not intact, as you turn their head, their eyes will move with their head, but then the frontal eye fields, the precentral gyrus, will cause the eyes to flick back with a corrective saccade back on target. And that's what we call a positive head impulse test. That shows that there's a problem with your vestibular ocular reflex, your peripheral system is not working. So here's an example of a head impulse test. So when this lady is turned towards the right, you can see her eyes stay fixed on the target. But when she turns her head to the left, can you see how the eyes correct? So they correct back to the center. So they skip off the nose and back onto the center again. So that's a positive head impulse test. When we look at nystagmus, we're looking at the direction of nystagmus, and we always describe nystagmus as being in the direction of the fast phase. In actual fact, what generally tends to happen is the fast phase is a corrective movement, and we get a slow drift across to the ear, which is not functioning properly. So this is a left beating horizontal nystagmus. We'll just go back to that again, so you can see the video. Implying there's a problem with our right inner ear. So we have a slow drift towards the abnormal side and a corrective saccade. If this is a peripheral problem, it doesn't matter what direction I look in, the nystagmus will remain in the same direction. So if I've lost my right inner ear, what will happen is I will get a left beating horizontal nystagmus, and that will beat to the left if I look to the right, if I look straight ahead, if I look to the left, if I look up, and if I look down. The nystagmus will stay in the same direction, and that's a peripheral lesion. If you have a central lesion, you're more likely to have direction changing nystagmus. And this is an example of gaze-evoked nystagmus, where we have the eyes flicking to the right when we look to the right, to the left when we look to the left. There's an up-beating nystagmus looking up, and we'll see a down-beating nystagmus in a moment when we look down. So direction changing nystagmus on direction of gaze is a central feature. And the final test of a hint is a test of skew. So this is a cover-uncover test. And again, you ask the patient to look at the tip of your nose. And if they have an intact system, their eyes will remain level and focused on the nose. If the eyes drift because of a central lesion, you'll get a corrective movement in the vertical plane, and this is called a skew deviation. So here's an example. As we move across, you can see the eyes are correcting up and down, and they're correcting, they're not staying still. So that is a positive skew deviation. So there are three very, very simple tests, but those three tests will allow you to tell whether the patient in front of you is having a stroke or not. So if all of these are present, so if a patient has a positive head impulse test, then nystagmus stays in the same direction regardless of gaze, and they have no positive test of skew, they have a negative test of skew, then you can be confident that the patient in front of you is not having a stroke. As confident as an early diffusion weighted MRI. It's as sensitive. However, if you have just one of these, there's a higher chance the patient is having a central event. So if their head impulse test is negative, so you remember me talked earlier on when we talked about the history, how patients with a peripheral disorder want to keep their head still, because if they move their head around, it makes them feel worse. And that's because they have a positive head impulse test. If you have a negative head impulse, you can keep moving your head around, and the vertigo will remain exactly the same. So a central disorder, you would have a negative head impulse test. You'll have direction changing nystagmus, or you'll have a positive test of skew, and you only need one of those. So you can start off with your head impulse, move on to your test of nystagmus, move on to your test of skew. And if one of those forms like this, then it's highly likely this patient's having a stroke and needs an early referral. So this is for an acute onset vertigo. So we now have the tools by which we can decide whether this patient is having a centrally driven vertigo or a peripherally driven vertigo. However, vestibular disorders can coexist. So in medicine generally, we always think about a large differential diagnosis from our history. We can narrow that down to a few disorders with our examination. We narrow it down more so with investigations until we get a final diagnosis. So traditionally, we always tend to look for a single diagnosis. But what we see with balance disorders is they can often coexist, and we can have more than one going on at once. And there's growing evidence that patients may have dual or triple therapies, which may explain why they then return back to you with slightly different symptoms. Not only do vestibular disorders coexist, but vestibular disorders and non-vestibular disorders can coexist, such as patients who are elderly are more likely to have BPPV and may also have postural hypotension, which often presents in a very similar way. Patients will say they get dizzy every time they get out of bed. When they roll over to get out, they get dizzy with their BPPV, and when they sit up, they get dizzy and lightheaded with their postural hypotension. Teenagers and those going through puberty have a higher risk of migraine and POTS syndrome simultaneously, and they occur together. And patients with diabetes are more likely, as you know, to have peripheral neuropathy, which means they can also develop vestibular hypofunction, and they also coexist. But in any patient who presents with dizziness, we need to be acutely aware of potential red flags that might need an urgent assessment. So these are the main red flags. If any dizzy symptoms and vertigo is progressively getting worse and worse and worse, that's a concern that this is an underlying central disorder. Any clear, hard CNS signs or symptoms would prompt an urgent referral, as would early morning headaches, indicative of raised intracranial pressure. Any ear discharge and hearing loss concurrent with vertigo would make you concerned about an invasive inner ear or middle ear disorder such as cholesteatoma or squamous cell carcinoma. And loss of consciousness is a red flag because there's no vestibular disorder that causes you to lose consciousness. So if a patient is losing consciousness with their symptoms, it means this is cardiovascular or neurological. This is not a purely vestibular disorder. So we have our patients with our acute event. We've decided that they haven't had a stroke and this is likely to be a peripheral disorder. So how are we going to treat that patient in front of us? As my colleague mentioned earlier, propylperazine is the treatment of choice. And it's the treatment of choice for lots of reasons, primarily because of its actions. Not only does it act peripherally as a vestibular sedative with its histamine blockade, but it actually also acts centrally as a dopamine antagonist to help to calm the chemotactic trigger zone. So it's great from a symptomatic perspective at reducing the nausea and vomiting as well as the vertigo itself. The dosage is anywhere between 5 and 10 milligrams. You can have it up to 3 times a day and at PRN use. But as with any medication, there's contraindications, and the biggest caution that I would definitely recommend is to be very careful about any other drugs that have extrapyramidal side effects. So beware of any co-prescriptions with those sort of drugs. And very importantly, we must avoid long-term use. So prochlorperazine is a vestibular sedative. If we lose vestibular function on one side from, say, a vestibular neuronitis, the brain adapts very rapidly, and we can upregulate the neuronal activity within the vestibular nucleus. And so what happens over time, if the brain is receiving regular signals, such as moving around, moving your head, vestibular rehabilitation exercise, then actually the system can recalibrate itself. But if you're constantly suppressing the vestibular activity with a vestibular suppressant like prochlorperazine, the central adaptation cannot happen, and the patients become very wobbly and off balance, and they start to lose confidence, and they're more at risk of falls. So it is an acute-only medication and should only be used for a maximum of 2 weeks, ideally up to about 7 to 10 days. And after that time, it should stop, and the patient should be encouraged to mobilize and do as much normal movement and activity as possible. Otherwise, patients could start to become deconditioned, they start to become anxious and apprehensive about their movements, and the symptoms gradually get worse and worse. But when we're treating with prochlorperazine, we also have to think carefully about what are we actually treating. So when we take prochlorperazine, it takes 30 minutes to get into the system, and it takes probably about 2 hours, 1 to 2 hours to get to peak blood levels. If your patient is describing seconds of vertigo, or even minutes of vertigo as episodes, then it is pointless prescribing this medication. Because by the time the medication has started to become active, their symptoms have settled anyway. So you wouldn't treat BPPV, for example, with medication. As my colleague described earlier on, it's loose otoconia, crystals from the utricle or the saccule floating into the posterior semicircular canal. And therefore it's a mechanical disorder. You've got debris within the canal, the debris needs to come out of the canal, and there's no medication that will solve that. However, what some patients you'll have will come to you and they've had BPPV for years and they take prochlorperazine regularly. But of course the prochlorperazine isn't effective. They think it is because they take the tablet and within a couple of seconds the symptoms have gone. But that's purely because that's the nature of the disorder. And it's very effective for vestibular migraine, and that's predominantly because it works centrally at the chemotactic trigger zone, and it's very good for those additional migraine symptoms such as nausea, vomiting, the horrendous feeling patients get with a migraine disorder. And so this study has been done here in India. This is the latest evidence and the results, not as yet been published. And this is a study looking at using prochlorperazine, 5 milligrams 3 times a day for a period of 7 days for patients with vestibular migraine. And the preliminary results show it's really effective with a very low rate of side effects and complications. And the clinical response and the symptom severity scores are much less after a few days of this drug. So in summary, to manage vertigo, the first thing we need to do is take a very careful history, detailed history. We need the answers to those 6 golden questions, which will help us to diagnose the underlying condition. If it is an acute presentation, we need to ascertain whether this is an acute central or peripheral disorder, and if it's a central disorder, identify that using a HINTS test and refer the patient appropriately, often to yourselves. But through that thorough history taking for repeated episodes, we can often get an indication of the underlying diagnosis. And treatment for acute vertigo should primarily be prochlorperazine, but for more prolonged episodes, there are other drugs available. Danuat. Cases. We have some case studies of vertigo if you'd like to do those. There are sort of 5 common cases that we could discuss. So, yes, yeah, I have them all here. So what we can do if you'd like to for about 5 to 10 minutes is go through some cases if everyone's happy with that. Mr. Chairman, would you be happy for us to do that? Are you happy with that? So what we'll do is I'm going to just point out just a few points in the history, and then see if you can identify what you think is the most likely disorder. We'll give a little bit more information and think if we think the same disorder is going on. So we'll start with the basics. So this is a 53-year-old teacher. She's had acute episodic vertigo whenever she looks up to write on the blackboard. It only lasts for a few seconds each time. She describes no hearing loss and tinnitus, and over the last couple of days she's also noticed it started to come on when she bends down to tie her shoes. So based on that snippet of information, just a very small amount of history, I want to think in your mind about which of these diagnoses you think is likely that this is. So we've heard BPPV. Let's have a bit more information. So it started a couple of days after visiting the dentist. She now tells you that also, because you're taking a careful history, that the symptoms are worse when she's lying down and turns over in bed. From an associated symptoms point of view, she has no headache or visual disturbance, and actually she has had symptoms like this before, and many years ago, after a minor head injury, she had a cluster of episodes almost identical. So can we have hands up for A, BPPV? Yep. B, Meniere's disease? C, neuronitis? D, E, vestibular hypofunction? So this is BPPV. So it's a really classic history. And what's nice about BPPV, it is almost like it's out of a textbook when the patient describes it. It's often when they turn over in bed, it can be when they look up and when they look down. And that's predominantly, as my colleague said, is because it's due to otoconia floating loosely within the posterior semicircular canal. That is orientated in this position, and it detects movement looking up, movement looking down, and turning over to either side with your head up, i.e. in bed. Those otoconia are loosened often by a minor head injury, like happened 2 or 3 years ago with her previous cluster of episodes, or any vibration to the skull. So dental drilling can stimulate BPPV, and she visited the dentist 2 days prior to this coming on. Ear surgery, neurosurgery, any vibration to the skull can form BPPV. And there are certain patients that are more prone to BPPV, such as those with hypocalcemia. So if you get that classic history, what you then do is a Dix-Hallpike test. And this is a Dix-Hallpike test. So you sit the patient on the couch, you get them to look up by about 30 degrees towards the side of their symptoms. If they say they get their symptoms when they turn towards the right in bed, for example, by about 30 degrees, and then lie them down with their head just below horizontal, again by about 30 degrees. And if you've got a couch where the head end goes up and down, that's better than have a patient's head hanging over the edge of the bed. And if they have a positive test, you see this characteristic nystagmus. So for the first few seconds they feel fine, and then suddenly they feel horrendously dizzy. You ask them to open their eyes, and they have a torsional nystagmus. So the eyes are actually rotating in the sockets. And what we tend to see is when we have the affected ear down, we have a geotropic torsional nystagmus, so the eyes rotate down towards the ground. If you get the eyes rotating in an ageotropic fashion, so they're rotating but in the opposite direction, that implies it's the other ear that you need to look at. So if you get that absolute classic textbook history, you get this finding on examination, BPPV is your diagnosis, and the treatment is a particle repositioning maneuver. So as we said, this is a mechanical disorder. These are crystals floating in the fluid of the semicircular canal. There's no medication that's going to solve this. They need a maneuver to shift those crystals out of the semicircular canal. And here is a diagram of the canal. You can see the posterior canal there on the right-hand side of the image is the most dependent, and that is where the crystals tend to get stuck. So our second case is a 33-year-old female. She's a busy admin manager. She's describing rotatory vertigo, and it's happening quite frequently. She's having 2 or 3 episodes a week. Each one's lasting about 3 to 4 hours, so she's getting quite debilitated with this. And she feels that it's provoked by head movements. During the episode, she gets nauseous. She gets a unilateral left-sided tinnitus. She has muffling of her hearing. She has a pressure in her left ear and the whole side of the left side of her head. And between episodes, she tells you she is completely well and has absolutely no hearing loss or tinnitus at all between the episodes. So based on that history, Can you have a think about what you think this diagnosis is likely to be? Okay, so you've got that in your mind. So we'll have a little bit more history. So she works at a computer, and she feels that movement on the computer screen, this is very common now, scrolling up and down, or turning ahead to look from one screen to another, tends to stimulate the episodes and makes her feel worse. During the episode itself, she gets blurring of her vision, and she cannot focus on the words on the computer screen. She can't concentrate on doing any task, and she often feels really quite hot and sweaty and flushed and nauseous. She becomes very sensitive to light and has to turn the brightness down in the room. And when the episode of vertigo is resolved after 3 to 4 hours, she's left feeling absolutely exhausted and fatigued. And when you ask if she's had any dizziness in the past, she says, well, she's not really had any dizziness, but she was very motion sick, both as a small child and as a teenager. So based on that additional information from that very careful history and those 6 golden questions, what do we think is now going on? Yeah, so absolutely. So this is vestibular migraine. So those initial parts of the history makes us think of Meniere's disease. She has a pressure in her ear, she has hearing loss, she has tinnitus, she has vertigo. Those classic features of Meniere's disease. But there are some clues in the history that point this away from Meniere's disease. She has visual disturbance with her disorder. You don't have visual disturbance with Meniere's disease. She has no symptoms in between attacks. So between attacks of Meniere's disease, patients have fluctuating auditory symptoms. They have a fluctuating hearing loss, a fluctuating tinnitus, and she has nothing between her attacks. But crucially also, of course, she doesn't have any headache. Vestibular migraine is an acaphalgic form of headache where you don't need to have a headache. So as you all know, we don't really know the underlying cause of migraine. It's probably genetic. People have a predisposition. You put a trigger in place, and that triggers an episode of migraine. What we are beginning to understand is that it's likely caused by release of calcium gene-related peptide, which stimulates the trigeminal-vascular system, causing a combination of vasodilatation, vasoconstriction, and stimulation of cortical spreading depression, as my colleague saw earlier on. But what we do know is, although that some medications that target that can help, for vestibular migraine, probably about 90% of patients can get control of their disorder rather than a cure by identifying what those underlying triggers are. And in actual fact, that works for all migraines. Only about 10% actually need medication. And unlike migraine, where we would use things like sumatriptan and carbamazepine, for vestibular migraine, things like propranolol low dose and amitriptyline or nortriptyline are really effective. And I often point patients to a website. Self-help websites are very good for patients. They can look up all of the potential triggers that might be causing their symptoms, work through them carefully, and 90% of patients come back at 3 months to see me in clinic having had no medication, purely just trigger identification and control, and 90% of them are better and haven't had any other episodes. And for vestibular migraine, there's no role for beta-histine. So as we said, the symptoms are very, very similar to Meniere's disease. They may or may not have headache. It's an acaphalgic form of migraine. They may or may not have hearing loss. One of the reasons people get hearing loss or a presumed hearing loss with a muffling of their hearing and a pressure in their ear is the migraine itself. So when we get stimulation of the trigeminal-vascular system, we get vasodilatation, not only in the meninges causing headache, but we can also get it in the mucosal surfaces of the middle ear and the sinuses. So we can get a stuffy, full-feeling ear, which can often make your hearing feel muffled. You can get a stuffy nose and sinuses, often giving you facial pain and pressure that is almost always misdiagnosed as sinusitis. But as ENT surgeons, if you haven't got any nasal discharge at the time of that feeling, by definition it isn't sinusitis, and it's probably facial migraine, which we see a lot of. And patients may or may not have tinnitus, and that's because one of the primary triggers for migraine is stress, and stress is also the primary trigger for tinnitus. But when we look at past history or family history of migraine, we don't just mean headache. We mean any of those acaphalgic forms of migraine. So babies, for example, present with cyclical vomiting or cervical dystonia, and they can be presentations of migraine in infancy. Children may have abdominal migraine, unexplained abdominal pain, bloating, diarrhea, feeling nauseous but no headache. And children also get limb and joint migraine, particularly in their knee and their shin. Colloquially, we call it growing pains, of course. But these are all migraine phenomena, and travel sickness and motion intolerance is a strong migraine precursor. And this lady didn't have a history of migraine, headache as such, but she did have that history of motion intolerance, which helps you with the diagnosis. And actually, the Bahraini Society have identified those key features in order to put together diagnostic criteria for Meniere's disease and migraine. And as we said from the history of that first slide, this patient doesn't get any fluctuating symptoms, auditory symptoms, between her episodes, which means by definition it can't be Meniere's disease, because point C of definite Meniere's disease and point B of probable Meniere's disease is that those fluctuating auditory features between episodes. And as you can see, the hallmark of vestibular migraine are those migrainous features, particularly visual changes. And actually, photophobia has a 95% specificity for vestibular migraine. When we talk about beta-histine, this is a common drug that's used for patients with dizziness. It's used long-term in a large number of patients with dizziness. But there are now 3 Cochrane reviews, and I did the one most recently in 2023. And we found essentially the same findings as the previous 2 Cochrane reviews. So these are systemic reviews looking at all the literature available. And currently there is no evidence that beta-histine is effective for prolonged vertigo and dizziness. We do have another case if you'd like to continue. So this is a 68-year-old librarian. She describes coryzal symptoms for about a week, after which she started to develop disabling vertigo. So it happened earlier on today. She's had it now for 6 hours. She's vomiting, she's prostrated. She has this gradual hearing loss over the past year, but no previous history at all of any vertigo or ear problems. So based on that history, have an idea of what might be going on here. Okay, a little bit more information. She's an ex-smoker. She's struggling to read. She can stand, but she's very unstable. And every time she moves her head, it makes symptoms worse. So you need to go and see her at home because she really can't get out of bed. She's lying completely still because every time she turns her head, she vomits. So what do we think is going on here? This is an acute vestibular neuritis, absolutely. So you would do a HINTS test if you were concerned about this being a central feature, and you would find a positive head impulse test. Patient's probably likely to vomit. You would find unidirectional nystagmus, and you would find a negative test of skew. So the treatment for this acutely is prochlorperazine, but only for about 10 days maximum, and followed by vestibular rehabilitation or getting back to as much normal activity as possible, and no long-term medication. You want this patient to recover. Otherwise, what can happen is they can turn into this case, which is case 4. So this is a 79-year-old male gardener, and he's had 2 years of feeling unbalanced. He cannot walk in a straight line, and wherever he tries to, he's wobbling off in either direction, more towards one side. And he gets quite embarrassed going outside because people say he looks drunk. During the last 2 years, he's had no vertigo at all. And he also has bilateral hearing loss and a mild tinnitus. So what do we think is going on here? So a little bit more information. So he's better in the house. So actually, you ask him, when he's walking around at home, he can just about keep in a straight line, and he's okay. However, if he turns the light off, he's a 78-year-old man, he probably needs to go to the loo in the middle of the night. When he does that in the dark, he bumps into the door frames and stumbles around. He also finds his symptoms are much worse if he's in busy environments like shops and supermarkets, places with lots of movement. And when you ask about his previous history of dizziness, has he ever had any dizzy symptoms before? He says, oh yes, just before I started feeling like this, just over 2 years ago, he had this prolonged episode where everything was spinning continuously for 2 weeks. The GP came out and gave him some prochlorperazine, but he's been taking it regularly ever since, 3 times a day since that initial event for the last 2 years. So what do we think is going on with this case? Absolutely. So he's got a unilateral vestibular hypofunction secondary to a vestibular neuronitis that has not compensated. So what's happened with this chap is that episode of prolonged vertigo he had 2 years ago was an acute vestibular neuronitis, a post-viral illness, just like that previous case. However, he was treated correctly with a short course of prochlorperazine, but what's happened is he's continued to take that medication regularly over the last 2 years. So that stopped any central compensation, stopped any central adaptation from happening, and now he's permanently and persistently unstable, cannot walk in a straight line. So the way I describe this to patients is that our inner ears work a little bit like aeroplane wings, and our brain is the pilot. And what we think about from a medical perspective is our ears are our vestibular system, and our brain, our pilot, is a combination of vision and proprioception. And by using vision and proprioception, we can generally compensate for a vestibular loss. So I describe to patients that if both wings are equal and the same, you can fly in a straight line and your brain, your pilot, doesn't have to concentrate very hard. But if one side dips, you're much more likely to wobble off and bank off to the side of weakness, unless your brain or your pilot can really concentrate hard to keep you straight. When he's at home, it's a familiar environment. He knows where all the obstacles are. He can use his vision quite easily to be able to maneuver and walk in a straight line. But as soon as he turns the light off, he can no longer use his vision to compensate, and he decompensates. Also, if he's in a visually rich environment with lots of colours, shapes, patterns, movement, like shops and supermarkets, he cannot use his vision preferentially because it's overwhelmed, and he decompensates there as well. So he's developed something called visual preference disorder, where patients start to need to prefer to use their vision to keep themselves balanced, as opposed to their vestibular system. So treating this involves coming off the prochlorperazine. But what we tend to see with this, particularly in the elderly, is this becomes a bit of a psychological crutch. And they find it very difficult to come off the medication because they feel that that is what's helping them. So again, the analogy I give, it's a little bit like those aeroplane wings, but the prochlorperazine is like having a weight hung off the lower wing. And it will never be able to pick back up again unless we can remove that weight. And that if we take the prochlorperazine away, then the brain can adapt and to correct itself. So I usually recommend coming off it slowly over a period of about 2 to 3 weeks. And that's because if you suddenly stop prochlorperazine, you can get a rebound vertigo, and the patients inevitably just go straight back on the medication again. You're back to square one. And simultaneous to taking them off and weaning them off prochlorperazine, give them directed physiotherapy, vestibular rehabilitation therapy exercises to help to accelerate that central compensation. And the final case, I think you're all going to get this. So this is a retired lorry driver, acute onset disabling vertigo, started 6 hours ago. He's vomiting, he's also prostrated. He has a pressure feeling in the left side of his head. His hearing has dropped on that side, but he's got no previous ear or vertigo symptoms. So what do we think is going on here? You could use exam technique, and it's the case we haven't discussed yet, obviously. So he's a heavy smoker. He cannot focus and read, and crucially, he cannot stand unaided at the moment. And when he moves his head around, it doesn't change his symptoms. They still remain the same. The vertigo just is continuous. So what do we think is going on here? Yeah, absolutely, a stroke. So of course, from when it's safe not to refer, it's all back to those first few slides, which is to use the hints test. Thank you very much.
Excellent, sir. We like to express our sincere Nandi and Abhinandanam. Malayalam words for Dhanyavad. For your learned address and excellent case presentations regarding vertigo. Being physicians, our first diagnosis in most of the cases will be sometimes different till this talk. Last case, our diagnosis will go in favor of a sensory ataxia. Yes, not so. Sensory ataxia and cerebellar dysfunction. These are the two things that will come to our mind, being physicians. Okay, now it is time for clearing your doubts and sharing our experiences with Professor Owen JUDD.
Is it, will it be needed to be done repeatedly?
So generally speaking, so BPV is the most common vestibular disorder that we see, although vestibular migraine is increasing in incidence all the time. But with BPPV, if you get an epi maneuver right, and there's a lot of false stuff on the internet, so I would suggest learning an epi maneuver because it's very straightforward and doing it correctly. But if you do it correctly, it cures 80% of patients on one maneuver. Of the 20% that remain, 80% of those are better after the second maneuver, and so on and so forth. So usually when I see patients, I will do an epi maneuver. If they've got a positive Dix-Hallpike test, I'll do an epi maneuver. I'll see them again 4 weeks later. And if they need a second epi maneuver, I'll do that, but 80% of them are better. And then if I need to do it a third time, there are other maneuvers that are possible. There's something called the CME maneuver, there's a Gaffoni maneuver, there's various other ones that you can attempt to try. But it's so rare to have to do it more than twice.
Absolutely. Every day I must be doing this Dix-Hallpike maneuver diagnostic of the posterior semicircular canal positional vertigo BPPV and a please maneuver to cure it. Actually, these two procedures are done simultaneously, one after another. I must be doing at least 10 times. If I see 40 patients a day, in the present day, it's so common that I'll be doing it at least for 25% of my patients seen in the OP. So it's very, very common. And the trick of the trade is doing it properly, as had been told by Professor OWEN JUDD. There a person is standing by name Harish. Where is Harish? Sit down. In all my talks, I bring him, I put him on the table, and I demonstrate it, and I teach it to the audience. But I do that mostly to the ENT fraternity, because I'm afraid it's very, very common. And as I will tell you something more. Professor OWEN JUDD was telling that if after the first correction, if the BPPV doesn't get cured, you may have to repeat it a second time. Because it's not always possible to reposition these canaloliths into the receptacle vestibule. So you may have to repeat it a second time. Sometimes it so happens that it is a presumption that BPPV is only of one side. BPPV might be bilateral. So if it is bilateral, at a time you can do correct only on one side. 2 weeks later, correct it on the opposite side. And you do it twice. The third week or the fourth week or the sixth week, the patient comes back with the same symptoms. Then the diagnosis is a little bit different. Though we club all these diagnoses under BPPV, there are two varieties. One is canalolithiasis, where the loose particles are within the canal. The other one is cupulolithiasis, where these particles get stuck onto the cupula. I told you about the gelatinous pillar giving inertia to the hair cells. So if the particles, if the otoconia are stuck to the cupula, it is called as cupulolithiasis. By positioning, these stuck particles will not get loose. So what you do is, you take the head of the patient and bang it twice on the examination table. That maneuver is called as Simmons maneuver. Well, it's simple when I say like this. You have to learn it properly. Once you bang the head, the particles falls off from the cupula, and then you go ahead with your please maneuver to reposition it. All these things are so beautifully described that you will enjoy it only if you do it. And there is a big point there, as is very correctly written there, no prochlorperazine. Because if you give prochlorperazine, you are cheating yourself. Just this maneuver is enough to cure the disease. Sometimes we give because going out of your office without a prescription, they will come back with a psychogenic vertigo. So you might prescribe sometimes. I'm not telling that, but the principle is these maneuvers.
Yes, it can do. Yeah, you can get so otosclerosis is a genetic condition, but it can be acquired with hormonal changes. You get abnormal balance between osteoclastic and osteoblastic activity around the foot plate of the stapes where it attaches to the cochlea. And so what generally tends to happen is slowly over time the stapes fixes and you get a conductive hearing loss. But you can get that abnormal activity spreading into the cochlea and the vestibule, and it can cause vertigo and it can cause sensorineural hearing loss in the long term as well.
Absolutely. We share the same opinion because we belong to the same specialty. Actually, otosclerosis is of two different types. One is cochlear otosclerosis and the other one is stapedial otosclerosis. Stapedial otosclerosis, you get only conductive hearing loss. Cochlear otosclerosis, you get both conductive and sensorineural hearing loss because the otosclerotic focus is an abnormal deposition of sclerotic material within the labyrinth. If it involves the cochlea, the base of the cochlea doesn't work properly and therefore you get a high frequency sensorineural hearing loss. But your question is whether it produces vertigo or not. When I describe the fixity of the foot plate and the extension to the cochlea, that is not the end of the story. A growing otosclerotic focus, it is a spongy thing. The correct name for otosclerosis is not otosclerosis but otospongiosis. It's called as otospongiosis because the initial deposit is a spongy-like material. Later on it becomes calcified and becomes otosclerosis. When it is a spongy material, it produces certain enzymes. And when those byproducts of the otospongiotic focus enters the vestibular system, you are likely to get a vertigo. But when you describe otosclerosis, that is not a cardinal symptom or that is not a diagnostic symptom, but it can happen.
Okay, I think there are no more questions and it is already 9:45. We are winding up the session and I like to express our sincere thanks once again to Professor Owen JUDD, Professor INDUDHARAN and Dr. Prof. Singhal for coming all the way and enlightened us regarding vertigo. Thank you.
Now we have come to the end of today's program. As a token of appreciation, I request Professor Gilles George to present the memento of thanks to Professor Owen JUDD. So please. I request Dr. Raji George to present the memento to Professor Dr. INDUDHARAN. Sir. May I request Dr. Sunny Arthur sir to present the memento to Dr. Professor Gilles George. Thank you. We appreciate the efforts of the Abbott medical team in organizing today's CME and making a great success. May I request Dr. Prof. Simran from the Abbott medical team to speak a few words.
Thank you, sir. First of all, I'm thankful to API Cochin for giving us this opportunity to have a session and have international vertigo expert Dr. JUDD talking about vertigo management. I'm also thankful to Dr. Gilles George, who is scientific chairman, for his smooth coordination and cooperation with our team, and Dr. Sheetal Binu, who is treasurer, and Dr. Sumesh Chaku, secretary of API. Also, I'm thankful to our expert panelists, Dr. INDUDHARAN sir, Dr. JUDD sir. thank you, Dr. Indudharan, sir, to how you highlighted the conceptual facts of vertigo and has shared the differentiating features of different types of vertigo with us, and also for driving down from THRISSUR especially. Then thanks to Dr. June for demonstrating the importance of history taking and bedside examination via these interesting case discussions, and also how to manage the acute vertigo. And finally, thanks to our respected delegates for your patient listening. Thank you so much.
On behalf of APA Kochi, we appreciate the efforts of all the delegates for making your time out and making this CME a grand success. Thank you, everybody. The meeting is adjourned for dinner and fellowship. Thank you.